Good afternoon, everyone. My name is Alberta Noonan, and I'm from the New England QIN-QIO, and I will be your moderator for today's webinar, the Alternative Payment Models and the Road to Success. Before we get started, these lines are currently open, so please either press *6 or manually mute your line.
The leader has muted your line. To unmute your line, press #6.
Okay. So before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of the webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and at that time I will provide you with instructions on how you can ask a question over the phone. You can also post a question in the chat box throughout the presentation. Please make sure to send your questions to all participants. And Radhika, would you like to start, please?
Thanks, Alberta. Hello, everyone, and welcome today to our webinar, Alternative Payment Models, The Road to Success. My name is Kelsey Baker, and I'm joined by my colleague, Radhika Savnitz. So on the next slide here, we just have a quick disclaimer that we at Health Centric Advisors are a contractor of the Centers of Medicare and Medicaid Services. But we at Health Centric Advisors, our staff, created these slides that we'll be showing you today. So here's an overview of what we'll go over. Today's webinar will cover quite a bit of information regarding the Quality Payment Program and alternative payment models. We'll go over a brief macro overview and then discuss what alternative payment models, or APMs, are and differentiating between MIPS APMs and advanced APMs. We will discuss what it means to be a qualified participant, or QP, how to determine that, and the benefits of being in an APM. We'll also discuss advanced APMs for 2018, the performance categories, scoring, and reporting requirements. We'll give some guidance to anyone preparing to report, and there will be some time at the end for questions. We also want to note, like Alberta mentioned, our colleague is in the room and can try to answer any questions via the chat box if you'd like to type them in there as well. So throughout this presentation, we will be using lots of acronyms. As we all know, CMS loves them. So it's helpful to have a little cheat sheet. Some of the more important ones that we will mention are APM, or Alternative Payment Model, QPP, or the Quality Payment Program, PI, which is Promoting Interoperability, what used to be called Advancing Care Information, ONC, the Office of the National Coordinator, SSP, which is the Shared Savings Program, and QP, which is Qualified Participant. Briefly, I'll go over MACRA. I'm sure that most of you are familiar with it, so this may be a review, but for some, there may be some new information, so it's important that we cover it. MACRA, which stands for the Medicare Access and CHIP Reauthorization Act, is a bipartisan legislation that was passed in 2015, and it repealed the Sustainable Growth Rate, or SGR, to try to reduce Medicare spending. This legislation combines three legacy programs: PQRS, or the Physician Quality Reporting System, VBM, or the Value-Based Modifier, and that EHR incentive program, and those three legacy programs combined created the QPP, or Quality Payment Program. There are two tracks for reporting, one via MIPS, or the Merit-Based Incentive Payment System, or via APM, or Alternative Payment Models. Reporting via the MIPS track includes MIPS-eligible clinicians not part of an accountable care organization or alternative payment model. These clinicians report individually or as a group on the quality, improvement activity, promoting interoperability, and cost category, and they get scored based on their performance. they may receive a positive payment adjustment based on their performance anywhere up to 5% for the performance year 2018. Clinicians reporting via the APM track may receive a 5% lump sum payment adjustment as they accept both risk and reward for providing coordinated, high-quality care simply by being part of an alternative payment model. And advanced APMs typically have a greater revenue risk and opportunity, and we'll discuss these all in greater detail later on in the webinar. So as I mentioned on the previous slide, an alternative payment model is a payment approach that gives clinicians added incentives to providing high quality and cost-efficient care to their patients. APMs can apply to specific conditions, care episodes, or populations. So for example, the oncology care model or the comprehensive end-stage renal disease model. Within alternative payment models, there are two different types: advanced APMs and MIPS APMs. Advanced APMs earn clinicians a 5% incentive for achieving threshold levels of payments or patients through the APM. So that will be 20% of patients seen through the APM and 25% of payments made through the APM. And again, we'll discuss that a little bit later on in more detail. So if a clinician meets these thresholds, they are then excluded from MIPS reporting requirements and that payment adjustment. If a clinician is in a MIPS APM and is not excluded from MIPS, they may be scored using a special APM scoring standard, which is designed to account for activities already required by the APM that they're a part of. So, for example, they eliminate the need for MIPS clinicians to duplicate submission of quality and improvement activity performance category data, and this allows them to focus on the goals of the APM. So why should I join an alternative payment model? If you're part of a practice that's considering joining an alternative payment model or organization that uses one, here are some benefits that we've laid out. So first, there is considerable support for quality payment program reporting, including robust IT and analytical support for practices and clinicians. So this might mean assistance with your EHR or maybe even upgrading to a better one. Could be assistance in pulling reports to help you review your quality payment program performance throughout the year so that you might have the opportunity to adjust workflows to better support the measures. Simply by joining the alternative payment model, you agree to performing high-quality, coordinated care to your patients. So this means that you get full credit for the improvement activity performance category. Plus, the APM entity submits data for the quality performance category on your behalf. With these flexibilities, the clinicians in the ACO can avoid the reporting requirements under MIPS, which will allow them to focus more time and energy on achieving the goals of the ACO. One other benefit of joining an alternative payment model is the increased number of opportunities for clinicians to engage in the premier population-based payment model, which can assist them in improving care coordination and outcomes for their patients. All right, let's dive right into the various types of APMs, and we'll explain them. So we'll start with MIPS APMs. To be a MIPS APM, the entity must meet the following criteria. One, that the APM entity participates in the APM under an agreement with CMS, that's the Centers for Medicare and Medicaid Services. Two, the entity must include one or more MIPS-eligible clinicians on the participation list. And three, that the APM bases payment incentives on performance, either at the APM entity or eligible clinician level, on cost, utilization, and quality. Participants in MIPS APMs receive special MIPS scoring under the APM scoring standard, which just means that the weights assigned to the MIPS performance category under the APM scoring standard might be different from the regular MIPS performance category weights. And Radhika is going to walk us through that in greater detail later on in the webinar. To be in an advanced APM, the entity must meet the following three criteria. One, at least 50% of the participants in the APM are using certified electronic health record technology. These certifications are made by the ONC, or the Office of the National Coordinator, and my colleague will type their site address in the chat box for folks to take a look at in the event you're unsure if your EHR is certified. Number two, the entity must provide payment for covered professional services based on quality measures comparable to those used in the quality performance category of MIPS. And three, the APM entity must bear more than a nominal amount of financial risk for monetary losses. In the advanced APM track of the quality payment program, eligible clinicians may earn a 5% incentive for achieving threshold levels of payments for patients through the advanced APM. And if you achieve these thresholds, you're excluded from the MIPS reporting requirements and the payment adjustment. And now let's see exactly what those thresholds are. So for the performance year 2018, eligible clinicians will earn that 5% incentive payment for 2020 for advanced APM participation in the performance year 2018 if they receive 25% of their Medicare Part B payments through an advanced APM or see 20% of their Medicare patients through an advanced APM. They'll need to send in the quality data required by the advanced APM, and the model's website will tell you how to send that in. If an eligible clinician leaves the advanced APM during the performance year 2018, they should make sure they've seen enough patients or received enough payments through an advanced APM to qualify for that 5% bonus. If they haven't met these thresholds, they may need to submit MIPS data in order to avoid a downward payment adjustment. If anyone is still unsure whether they're a qualifying APM participant, you can actually check your QP status on the qpp.cms.gov website, and there's a link later on in this presentation that you'll see. Again, there are certainly lots of benefits for participating in alternative payment models. So as you can see in this graphic, not participating in an APM, you receive MIPS adjustments. Under the APM, you can receive MIPS adjustments plus the rewards specific to your APM. In a MIPS APM, you can receive APM scoring standard towards the MIPS adjustment plus any rewards specific to your APM. And in an advanced APM, you'll still receive rewards specific to your APM, but also get that 5% lump sum bonus if you're a qualified participant. On this slide, you'll find a list of the advanced alternative payment models for 2018. I'm going to briefly go over each one, but we won't get into great detail about them. So first is the bundled payments for care improvement advanced model, or APCI advanced, which is comprised of 4 broadly defined models of care, and it links payments for multiple services beneficiaries receive during an episode of care. Next is the comprehensive end-stage renal disease care, which is a 2-sided risk advanced alternative payment model, and it's designed to identify, test, and evaluate new ways to improve care for Medicare beneficiaries with end-stage renal disease. Next, you'll see the Comprehensive Primary Care Plus, or CPC Plus model, which is a national advanced primary care medical home model that aims to strengthen primary care through regionally based multi-payer payment reform and care delivery transformation. Next, you'll see Medicare Accountable Care Organization Track 1 Plus model, which is a 2-sided risk arrangement that assumes limited downside risk, so less than the tracks 2 or 3. So we'll skip next one for now and look at the FSP, or Shared Savings Program Track 2, which is a 2-sided risk arrangement and may share a greater portion of savings than the Track 1. And then we have the SSP, or Shared Savings Program Track 3. Again, a 2-sided risk arrangement, but they take on the greatest amount of risk, but they may share in the greatest portion of savings if successful. Now let's look at the next generation ACO model, which is another advanced alternative payment model that was built upon experience from the Pioneer ACO model and the Shared Savings Program, and it offers new opportunities in accountable care. Then we have the Oncology Care Model, a 2-sided risk model designed to improve the effectiveness and efficiency of oncology care, and the Comprehensive Care for Joint Replacement, or CJR payment model, So this model aims to support better and more efficient care for beneficiaries undergoing the most common inpatient surgeries for Medicare beneficiaries, which are hip and knee replacements. Those are also referred to as lower extremity joint replacement, or LEJR. Okay, let's get into the 2018 Alternative Payment Model Performance category. So first, cost. If you're in an alternative payment model, you will not be scored under the cost performance category. Next, we have quality. Quality accounts for 50% of the final APM score, and this category is scored at the APM entity level. And the APM will report data via the CMS web interface for a full calendar year. Next, we have promoting interoperability, or what was formerly known as advancing care information. This category accounts for 30% of the final MIPS score, and for FSP, Shared Savings Programs APM, those participant TINs are required to submit data to CMS, and they receive a weighted TIN score based on performance and number of clinicians under the TIN. And finally, APM entities receive full credit for the improvement activity performance category due to participation in the advanced payment model. And again, Radhika will go into a little bit more detail on the specifics within each category and the differences in reporting requirements for each alternative payment model. Snapshot date for APM. So in order for a clinician to be an eligible participating clinician in an alternative payment model, they must be on the APM participation list on at least one of the snapshot dates for the performance period. Otherwise, the eligible clinician must report to MIPS under standard MIPS methods. QP, or Qualified Participant Determination methodology, is made by identifying eligible clinicians participating in the advanced APM, identifying attribution-eligible beneficiaries using Medicare Part A and B administrative claims data and Medicare beneficiary enrollment information, then calculating the payment amount threshold score at the APM entity level, and calculating the patient count threshold score at the APM entity level, and then they can determine QP status. So the first QP determination will be made based on data from January 1st through March 31st. The second QP determination date will be made June 30th, and the third will be made on August 31st. There is a fourth snapshot date of December 31st. However, we want to note that this is only for Shared Savings Program full TIN MIPS APM, which we have a little bit more information on in the next slide. For Shared Savings Program full TIN MIPS APM, a fourth snapshot date for Qualified Participant or QP determination has been added, December 31st. So quickly, what is a full TIN MIPS APM? Those are defined as alternative payment models that require all individuals and entities going through that TIN to agree to participate in the APM, like in the Medicare Shared Savings Program. This will allow any clinicians that join the MIPS APM anytime between August 31st and December 31st to benefit from the APM scoring standard and group reporting. For split TIN APM, which essentially are just APMs that allow participation at the individual MPI level, such as the Next Generation ACO, there are only those first three snapshot determination dates, March 31st, June 30th, and August 31st, that will be used to determine participation and applicability of the APM scoring standard. If a clinician joins a split TIN APM between August 31st and December 31st, he or she will be subject to MIPS, and the APM scoring standard will not apply. So similar to MIPS, the performance period for alternative payment model reporting for 2018 is a full calendar year for quality, January 1st through December 31st, 2018. Promoting interoperability and improvement activities are both a minimum consecutive 90-day period. So this period needs to start no later than October 2nd, 2018 to end by December 31st, 2018. Now I'm going to hand it over to my colleague, Radhika Savnik, who will walk us through the performance categories, measures, and reporting requirements.
Thank you, Kelsey. And I will start with the performance categories, and I will start with quality. So if you're part of an APM, the APM entity will report your quality performance category via the CMS web interface. When you report via the CMS web interface, you report on 15 CMS web interface measures. These are primary care focused measures, and out of which 14 are scored. CMS will identify 248 beneficiaries from your APM's Medicare Part A and Part B eligible population. So you have a pre-selected population of beneficiaries that will be in your denominator for your quality measures. Maximum points you can achieve in this category are 140 points plus any bonus points. These quality measures are scored against MIPS APM benchmarks. You will receive anything between 3 to 10 points based on your performance. Majority of the alternative payment models have a weightage of 50% for quality performance category. In a scenario where CMS determines there are not sufficient measures applicable and available to eligible clinicians in a quality performance category will be reweighted to 0%, and promoting interoperability performance category will increase to 75%. And improvement activities performance category will be reweighted to 25%. The next slide shows APM quality measures. I will not be going into the details of each of these measures. This is just a quick overview for you to see what sort of measures you need to report via the CMS web interface. Like I mentioned earlier, these are mostly primary care based. Going on into the interoperability performance category, abbreviated as PI, formerly known as Advancing Care Information, or the ACI performance category, has a weightage of 30% in majority of the alternative payment models. Each participant in the APM entity, with an exception of next-gen model, has to submit PI data. And at the end, you will receive a weighted TIN score. In a situation where reweighting of PI performance category needs to be done, for example, if 75% of clinicians in a TIN are non-patient facing, then PI performance category gets reweighted to 0% and quality will be reweighted to 80%. And improvement activities will remain to 20%. Maximum points that can be earned are 165% points. Base score accounts for 50%, and there are about 4 to 5 base measures to report to, depending on your EHR certification year. You can report on PI objective measures and objectives and measures if you have an EHR that is 2015 edition or a combination of 2014 and 2015. If you have a 2014 edition of certified EHR or a combination of 2014 and 15, then you can report on 2018 transition PI objectives and measures. Performance measures count for 90% of 165, and there are about 7 to 9 measures based on the certification year of your EHR. And then you can earn another 25% points in bonus points. You have to report data for a minimum 90-day period. That means your last performance period starts on October 2nd for this performance category. Moving to improvement activities performance category. If you are part of an APM, you will get full credit for this performance category. Reason being, APM entity signs up to perform various improvement activities. For example, CPC APM model meets the medical home model criteria. SSP models include activities like collecting and following up on patient experience and satisfaction data on beneficiary engagement, as well as practice improvements that engage community resources to support patient health goals, etc. Next-gen ACO models engage in improvement activities like prevention and intervention for patients with co-occurring conditions of behavioral or mental health conditions such as depression screenings and follow-up, and so on and so forth, and hence APMs get full credit in this category. For the cost performance category as well, APMs work on cost utilization measures and hence are scored in this performance category. In this section, I will be going through the reporting requirements for a few of the APM models. I'll start with the MIPS APM MSSP Track 1 reporting requirements. For quality, it weighs 50%, and eligible clinicians in the ACO or the APM entity get a quality performance score based on CMS web interface quality measures and caps for ACO quality measures that are reported by the ACO. For promoting interoperability, that weighs 30%, and ACO participant can report at the group level or solo practice level for eligible clinicians that are subject to PLAN. Data is aggregated and weighted to get a single score that applies to all eligible clinicians. You don't have to submit anything for IA performance category. You automatically get full credit for participating in an APM. Going into the advanced APMs, MSSP Track 1+, 2, and 3. These are very much similar to the Track 1. Quality is 50%, promoting interoperability is 30%, and improvement activities is 20%. Again, reporting is exactly same like Track 1. Going into the next advanced APM model, next generation model. Again, quality as the SSP tracks, it weighs 50% and is reported via the CMS web interface. The ACO will report on behalf of the participant. For PI, however, unlike SSP tracks, you don't have to submit any data for this performance category. Only requirement is that 50% of the participants should use a certified EHR technology. And again, similarly for improvement activities, you automatically get full credit for participating in an APM. Going into the all-payer combination model. This model will be available starting next year. This is just a quick overview for you to see what's coming up next year. From performance year 2019, there are two ways you can become a qualified participant or a QP. One is the Medicare option, where the clinician can achieve QP status exclusively based on participation in advanced APMs within Medicare fee-for-service by meeting the threshold. The threshold for performance year 2019 for payment amount is 50%, patient count is 30%. The other method is when a clinician meets minimum threshold under Medicare option, she may request a QP determination under all payer combination option. The clinician may become a QP based on combination of participation in advanced APMs within Medicare fee-for-service and other payer advanced APMs offered by other payers. So what are the other payers? Other payers include Medicaid, Medicare health plans, including Medicare Advantage, CMS multi-payer models, other commercial and private payers. And one important note is that only clinicians who do not meet the thresholds to become QP under Medicare options are able to request QP determination under all payer combination options. Okay, so you are part of an APM entity. So what do you need to do? In this next section, we will walk you through the steps for preparing for performance year 2018 if you're part of an APM. The first step would be to ensure you are on the participation list of an APM. So last year when we were reaching out to eligible clinicians, a lot of them were under assumptions I am part of an ACO and I will be covered. And then there was panic around the reporting period. And for some reason, they weren't on the list. The most important piece to this is to ensure you are on the participation list of the ACO or the APM entity. Easiest way to do this is you can contact your APM administrator and ensure that you are indeed on the participation list by August 31st, final snapshot date. There is a post-snapshot date, December 31st. It is available for full-pin MIPS APMs. This post date of December 31st will be used to identify the MIPS eligible clinicians who are on APM entities participation list for full PIN APMs. There is a QP lookup tool on QPP website to check your participation status. The link is displayed on the slide and my colleague will be putting it in the chat box as well. Once you are confirmed you are part of an APM, you need to determine your data submission requirements. APM entities submit quality on clinicians' behalf, but individual PINs must report on base measures for promoting interoperability performance category depending on your certification year of your EHR. And you can submit any performance and bonus measures if they apply to you. Clinicians have the choice to submit their data via any submission mechanism, and data submitted should demonstrate minimum 90 days of performance. Once you find out about the data submission requirements, you need to prep and evaluate and assemble data for reporting. You have to put in place any workflows and processes that you need to record your quality data. A simple example would be to ensure you have the right fields in your EHR to record your quality information. Ensure your APM can access the quality information you have recorded over the performance year, since they will be the ones who will be submitting data for you. Similarly, record your PI performance category data. Make a determination on which submission mechanism you will be using to submit data. Find out in advance how to extract data and in the format it can be submitted through your chosen submission mechanism. Ensure that the reporting period aligns with the data included in your reports. The last step in this process is data submission. The data submission period for performance year 2018 will be from January 2nd to March 31st of 2019. But CMS Web Interface submission period is only for 8 weeks, sometime between January 2nd and March 31st. Your APM entity will report data, your quality data via CMS Web Interface for full calendar year. You will have to submit EI data to CMS via your chosen method. Of course, there are exceptions. If you are a part of a next-gen APM entity, you won't have to submit any data. Once you have submitted your data, you need to ensure that the submission was successful. And that's about it. You may now know final MIPS Score is now available. You can log on to qpp.cms.gov and log in with your EID and credentials to view your score. And now we will open it up for questions, and you can press pound 6 to unmute or type in your question in the chat box. While you're doing that, I will go through some of the resources that are available to you. The first link is the New England QIN-QIO macro website. The website has tools and materials that were created by our team on various aspects of the quality training program. You can also ask us a question via our website. The second link on the slide will take you to the web page to which you can ask us a question. The third link on CMS QPP website. The third link is the CMS QPP website, and the last link is the CMS QPP resource library. And this is our contact information if you want to get in touch with us at a later time.
All right, so we have a couple of questions in the chat box that we'll go over. So Anne submitted a couple of questions. First, she asked, how do TCPI networks qualify as a MIPS APM? And they can't. They're not a MIPS APM. It's a different program. And then she submitted a second question. She said, I'm sorry, but I'm still not clear. Can an EC who is also a QP get both the MIPS adjustment and the 5% APM bonus? And no. If an eligible clinician is a qualified participant in an advanced alternative payment model, they don't get the MIPS adjustment, but they do get that 5% APM. Hope that answers your questions, Anne. And then Betsy submitted a question. How does an individual provider report MIPS when they're working for a group? We were unable to do this last year for those providers who joined after the 1st of September. I'm just going to repeat the question one more time. So how does an individual provider report MIPS when they're working for a group? We were unable to do that last year for those providers who joined after the 1st of September.
So I'm thinking that you're referring to submitting data, and you are correct. There were some limitations on the CMS portal, which is, I'm going to assume again, what you are referring to. Basically, if you had a participating PIN that was part of an APM and a handful of clinicians within that PIN that joined after that final snapshot date, due to the limitations of the portal, pretty much as long as you submit as a group for your PIN, which you would have under the APM, you would get credit for those clinicians. Now, I'm also going to add a caveat to all of that. We don't actually have access to the portal, so I'd be very interested to hear from the individual who asked that call if you have received a positive payment adjustment for those clinicians, or if you received a penalty, or if you've even checked your 2017 participation yet. So please let us know. I'm definitely interested to hear if it worked out in terms of group reporting or if you received a penalty for not reporting.
All right, so maybe we'll hear back from her on that. Hopefully that answers the question. So, looks like someone asked, can you review how the MIPS category weighting will be changing over the next couple of years? My understanding is that the percentage rate for each change due to recent rulings, including the cost of leeway at 10%. So, yeah, well, we can definitely, take that offline since this is just for this year about alternative payment models, but we can put our contact information in there.
And we're having an open call, one of our typical monthly open calls next Wednesday, July 25th from 11:30 to 12:30, where I'll be talking about a lot of the changes that are coming with the 2019 proposed rule. Something to keep in mind is that although CMS oftentimes in the proposed rule includes some discussion of future years of rulemaking, because they put these rules out every year, you should be aware of what's coming for multiple years down the road, but it really only affects the next calendar year.
Okay. Okay, so someone asked, someone placed the agency in an APM. Can I back off of the APM at this time and work as MIPS only?
You would need to check with your Center for Medicare and Medicaid Innovation. I don't believe mid-year you can actually come out of your APM agreement. That's an agreement that you establish with CMS, usually because you're part of an ACO. So I can't speak to that specifically because it's a contractual agreement outside of our purview. I see the second question this individual asked is about CPT codes changing 10-1. That would also be part of the proposed rule, and we will be talking about that, although we will not be getting into the evaluation and management code changes and other changes coming to CPT codes, because that's, while included as part of the quality payment program, really, again, outside of the actual components of the program, which is what we handle.
Great. Okay, looks like we have another question. How do you know in what area you need to improve your score? So I guess that is just based on your submission mechanism, how you're reporting, what measures you're reporting on. It totally depends. So if you are reporting via the portal for promoting interoperability and you're using an EHR, maybe you can pull reports to see your performance over the year. That's a little bit of a tricky question, but if you would like to touch base offline and like a little bit more one-on-one help with some of those questions, we're happy to discuss that. Okay. Anne asked, how are QPs notified about their adjustments? Would that come from the APM or from CMS, or does the QP need to look it up on the portal? So yes, the APM entity will notify their QPs about their adjustments. So thank you, Anne. And I see one more question on here from Lisa. Okay. We submitted MIPS as a group and received feedback of 100 over 100 for the 2017 performance year. However, on the QPP site, we began seeing a large subset of our physicians as subject to scoring by the next-gen ACO, under which they are preferred providers, even though the vast majority of their patients are seen outside of the context of the ACO. We do not have a score for these physicians and are hearing from the ACO that they believe our providers will still ultimately be scored, adjusted under our group submission and not part of the ACO. How can we determine if these individuals should be scored by MIPS or the APM?
So did you receive group reporting, as you said, the 100 over 100 for MIPS performance? That would be your score for your group clinicians. Preferred providers are a tricky topic in APM. Really, the only clinicians in an APM that would receive the APM bonus would be the Advanced Alternative Payment Model Qualifying Participants, which would get the 5% lump sum bonus. If you are in a MIPS APM, you would be subject to a MIPS payment adjustment. Now, I'm not sure where the clinician fell, but more than likely you're reporting through an Advanced Alternative Payment Model. Preferred providers truly are not on the participant list. They're those exactly what they say, preferred providers that often have some sort of contractual agreement with the APM in terms of services, maybe they're specialists, I don't know what your practice type is, but you would more than likely receive the MIPS payment adjustment. And just so you're aware, we've heard that perfect 100 scores are receiving roughly a 2.02 positive adjustment. So I don't know if you have that documentation, what you've seen yet on the portal, but that's roughly where you should be looking for your payment adjustment information.
Thank you. Okay, and it looks like our colleague Dushara put a link to the CMS resource library for alternative payment models if you'd like a little bit more information on them. She posted that link there in the chat box. We do have a question from Kanu Patel asking about some more information on promoting interoperability. So, Kanu, we are happy to take it offline if you'd like a little bit more information about each performance category or you want some more overall information. Our contact information is still on this slide, so feel free to send an email or shoot us a call, and we can definitely go into a little bit more detail about that for you. So again, if you'd like to ask a question over the phone, it's #6 to unmute, or you can type it into the chat box.
Hello?
Hello?
Hi. My name's Jennifer, and I had a question on, we received our 2017 feedback, and under the ACI score, we scored lower than we anticipated. But we're not sure. I've reached out to CMS, but I didn't know if anyone else has had any luck in seeing on their feedback any details underneath that ACI score. Even when we log in as one of the two practices that are part of our ACO, it's still just showing the actual score and not any information on how they came up with the overall score. So I didn't know if anyone had any other information that could help us on that.
So thank you for bringing that question up. That's a great point. So APM currently, if you go into the portal to get your score, for advancing care information now promoting interoperability, you're 100% correct. You are only able to see that aggregate score for your entire APM entity. There is not currently any functionality to allow for the breakdown of each TIN, depending on how many TINs within your APM, and even then more granular into each measure. We have brought this up to CMS numerous times, as it sounds like you have as well. They are hopefully working on a fix for that. I just don't know of any date. And honestly, I hate to say it, it might not be this year. It might be a future initiative that they allow and roll out functionality to allow for that more granular dissection under score. But it has been brought up. Lots of groups are very interested in the same information as yourself. So know that it's out there and hopefully being worked on in a timely manner.
Excellent. It's good to know that we weren't missing it. Do you know even at the practice level, we haven't been able to see it when we log in as a practice, because we only have two, and so we work for the practices. And even they're not able to see sort of what CMS accepted as their submissions. Do you know of anything?
It's not available for anybody unless you did individual reporting. And then obviously you have your score specifically for the measures that you submit.
Okay, perfect. Thank you so much.
Absolutely.
Hello, everyone. While we wait for some more questions, I want to thank you for a great discussion, and I have a few last-minute announcements. As a reminder, we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out today's webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as a link to the event page on our website. The slides are available on the event webpage. Within the next few business days, a recording and transcript of this webinar will also be added. I've put that link in chat for you again. And are there any last-minute questions? You can press #6 to verbalize, to speak over the phone, or you can unmute your phone manually.
And just a quick note, our colleague is putting the registration link for the open call that we're going to be holding on Wednesday, and we'll talk more about the proposed rule and some of the changes that are coming for year 3 of the program. So if you're interested, please register for it.
Thank you, everyone, for joining our webinar, and have a great day.